Good day. My name is Michelle Lavander. I'm the director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Ghosted, Desperately Seeking Mental Health Care. For many Americans, finding a mental health care provider is an exercise in futility. After signing up for a health plan with a long list of providers, many soon discover, after countless phone calls, how hard it is to find a therapist or psychiatrist who actually takes their insurance and sees new patients. This is the stuff of nightmares for individuals seeking treatment for a mental health crisis and who are ill-equipped in that moment to navigate a system seemingly stacked against them. In our webinar today, we'll learn about the human cost of these ghost networks and hear why insurers may have little incentive to fix error-plagued directories of providers in their network. More broadly, we'll ask what this means for the ongoing struggle to achieve mental health parity in this country, and we'll offer ideas on how journalists can report on the hurdles to mental health care in their community. Our distinguished panel includes Max Blau, a reporter with ProPublica South Unit, covering healthcare, public health, and the environment. Before joining ProPublica, he was an independent journalist who published stories in national outlets, including The Activist, The Atlantic, Time, and Stat. He has worked as a staff writer for CNN, Atlanta Magazine, and the Atlanta Alt Weekly Creative Loafing. He also co-founded Canopy Atlanta, a local news organization that pays and trains community members to become journalists. Abigail Berman is an attorney at Motley Rice, where she represents consumers in litigation against large tech companies. She was previously a Justice Catalyst Public Rights Project Fellow at Yale Law School, focusing on state regulation of health insurance provider directories and regulatory approaches to expanding abortion access. She received her law degree from the UC Berkeley School of Law. Prior to law school, she was a legislative assistant for Representative Joseph Kennedy III of Massachusetts. Dr. Robert Lee Trussman is the chair of psychiatry and behavioral medicine at Virginia Tech Carilion School of Medicine. He previously was a professor of medicine and psychiatry at the University of Connecticut School of Medicine. He is the chair of the American Psychiatric Association's Council on Healthcare Systems and Financing, a board member of the American Hospital Association, and is counselor to the American Association of Chairs of Departments of Psychiatry. He chaired the 2023 APA work group on the future of psychiatry. This webinar is made possible thanks to the generous support of the National Institute for Healthcare Management Foundation, the Commonwealth Fund, and the California Endowment. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format. We'll be hearing from speakers first, and then we'll turn it over to our audience for questions. Please feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel, and you can also write us there if you're experiencing technical problems. Now let's get underway. Max, let's start with you. Can you walk us through your recent reporting on ghost networks? Help us to understand the effects they have on real people at a time when they're at their most vulnerable.
Absolutely. I'm going to share my screen so I can show you a bit of ProPublica's reporting. Earlier this year, our team of 4 of us set out to really understand the ways that insurance companies were interfering with the mental health care benefits that ordinary Americans paid for and were entitled to. But for one reason or another, we're running into problems along the way in terms of actually seeing providers and having claims approved. This is ultimately the series of stories has become a series called America's Mental Barrier. And we've published 5 or so stories to date, with an additional set of stories coming over the course of November and December. Early on, our team was talking with different experts and learning about the landscape of why it was so hard for people to get mental health care. One of the first stories our team really focused on was looking at the way that insurers had left mental health providers had left insurance networks. The we had spoken early on with a handful of providers who described the experience of, getting into the field to see as many people as possible, without regard for, the amount of money they made or the kinds of benefits they had. But over time ran into, there was a pattern we saw, heard from in the providers we were speaking with, about how various restrictions from the insurance companies, whether it was in the form of pressuring them to do lower cost, shorter segments, or trying to aggressively audit them for providing, too much care, all the way down to getting paid at reimbursement rates that had fallen behind inflation and had not, in some cases, been increased in over a decade. A combination of different factors were driving these providers to leave insurance networks and to only accept cash. Over the course of 6 or so months, our team spoke with hundreds of providers, and we collaborated with NPR to tell the story about the one facet of the restrictions that were leading to it being harder for patients to get mental health care. Along the way, as our team was reporting this story, and here you can see two of the providers that were part of that. All of our team was individually looking into different components of the insurance industry to better understand these other facets of the restrictions that were leading to restricted mental health care benefits. And one of them, in a conversation I had with a mental health and parity lawyer early on, led me to meet someone named Barbara Weber, who is the mother of Ravi Coutinho. And her story stood out to me because her son Ravi had tragically passed in 2023. And this lawyer who had introduced me to her mentioned that she had compiled a chronology of events around the nature of her son's death in the months leading up to it. So as Barbara, who's pictured and with Ravi as a child in the bottom right, as we started chatting, and I got into reading her 4,200 word timeline that she had provided me, I could really see that there were a lot of different problems that Ravi and her had experienced in trying to get him the mental health care and addiction treatment that he was seeking. Ravi was someone who struggled with depression, anxiety, and alcohol use disorder. He was 36 years old, a one-time college golfer who had turned his love for the sport into a business that he planned and booked vacations for other golfers at some of the world's most famous courses in Scotland and in other countries. And Ravi, though, over the course of the 2015 forward, started to struggle with his mental health and addiction illnesses, and things really took a turn for the worse during the course of the pandemic. And he was living in Texas when he started to get some treatment. He went to rehab. He found the right therapist who not only helped with his depression and anxiety, but also specialized in seeing patients with addiction, and was able to help them kind of work through some of the underlying issues that triggered or exacerbated his drinking. And all of this led to a decision that he made at the end of 2022 to move to Phoenix, where he had spent some of his formative years in high school living there, and thought it would be a good place to get a fresh start. To do that, he needed to go buy a new insurance plan for the state he was moving to. And as he was shopping around, he ultimately decided to pick one sold by Ambetter, which is a subsidiary of Centene, the Ambetter is the um, largest insurance product available, or most popular insurance product available on the ACA. And the story, if you haven't read it yet, really hones in on Ravi's months in Arizona, in which call after call, after he was making call after call to different therapists to try to continue his care as he had received in Texas, but none of all the calls he made either led to people who no longer accepted Ambetter or could not see him because they weren't accepting new patients. And over time, the story progresses. The insurance company can't help him to get to the care he needs, and he tragically passed away likely due to complications from excessive drinking in May of 2023. And this ultimately led to our story that chronicles his journey, his perilous journey through a ghost network. In order to tell, I mentioned earlier that Barbara had shared with me this chronology she had assembled based on her own experiences and memory. But to really report that out and to reconstruct Ravi's final months, I needed to get a whole set of records. As a healthcare reporter, I'm used to having records in hand from care that did happen. This story was particularly challenging because I had to figure out a way to reconstruct moments and to tell the story of someone not getting care over and over again. And it was not as if a surgery had gone wrong and there was a detailed paper trail of that in a hospital record. I had to come at this from a lot of different angles to reconstruct what happened. Through a combination of police records, court filings, over 1,000 pages from hospitalizations and from his insurance records, that both of which Barbara helped me obtain, as well as having access to his and Barbara's phone in the form of call logs, so I can figure out when he called Ambetter customer service and for how long, text messages, and of course doing interviews with Barbara and his other close friends from this period of time. I was able to really hone in on specific moments that there was a failure in helping to get Ravi the healthcare he needed. A lot of systems failed Ravi. There was parts of that. There were problems that happened in the course of his care at various hospitals from individual providers. To some extent, one could argue that Ravi made in certain moments choices that were not the best for him. But I think when you looked at all the different systems, whether they were healthcare related, law enforcement related, even 988, for instance, like there was one that stood out above the others, and that was the role of insurance, and in particular this concept of ghost networks. To kind of hone in on that, though, and to figure out the idea of like how a ghost network was more than just a problem of a kind of a bureaucratic problem is the way I initially saw this. I spoke with over a dozen experts to including Abigail and Dr. Tressman and showed them ways to show them what I had seen and just to kind of talk through what I was seeing and to make sure I was kind of honing in on the right investigative angles to be considering Ravi's story. And over the course of these conversations, there was a theme emerged that insurance, the way Ambetter had handled this case, and specifically the inaccuracies in this provider directory were were roadblocks that he had run into over and over again during his course of seeking care. And it was that in and of itself was worthy of being kind of a centerpiece in the accountability like themes of this story. And so I'll stop there for now because I know we're going to hear from Abigail and Dr. Tressman, but that's sort of the journey of how the story came about. And I will say, like on the other side of reporting this, one of the things that I am left with that is different from where I started is that ghost networks and these errors that live within a provider directory are a life and death matter in some cases. And I think Ravi's story really exemplifies that. And these are errors that should not exist in the product that is being sold to people like him or to any of us who have insurance. And our country is really grappling with like how from a regulatory and a perspective of how to grapple with that. And I think I'll stop there because I know Abigail and Bob both have a lot to share on this as well.
You did, yeah. Thank you, Max. I'm still really shaken by Ravi's story, and as you read over this sweeping series, really the bureaucracy is almost like a character in the story. Can you hear me? Yeah. Okay. Good. Abigail, let's turn to you. Help us understand some of the forces behind what Max just described. How do we get here? What can be done to address these ghost networks? And how can reporters assess the quality of an insurer's in-network provider directory if they're trying to report on some of these issues in their community?
So, and I just want to echo what you said about Max's reporting. I think so much of the issue with ghost networks is just giving people the language to talk about what they're experiencing, because everyone who hits one, I think people tend to think that they have failed to find a doctor and don't understand it as their insurer failing to get them a doctor, and understand this as a systemic issue. So in terms of what's going on and how we got here, we're at a place where most states and the federal government do have laws related to accurate directories, but as anyone who has tried to find a doctor can attest, these laws really aren't working well. I actually got into this issue because I couldn't find a doctor when I was in law school and got so mad about it that I wrote a paper about it. So there is still this very large gap between what exists on paper and what consumers are actually experiencing. And the reason for that is that these laws are on the books, but they aren't enforced at all. Regulators, and there's a couple of problems with these laws and the way the enforcement process works that explains why this is happening. So the first is that regulators aren't aggressively enforcing the laws to the extent that they can. Most state insurance regulators are complaint driven. They are responding to consumer complaints as they come in rather than proactively surveying the conduct of insurers with regard to their directories. The problem with this is that there are very, very few consumer complaints. In some states, the numbers are under 100 a year, even though we know this issue is much more widespread. And how many of you or your friends and family would immediately think to complain to a state insurance regulator when you're having an issue with your insurer? A lot of people don't even know that they exist. Their websites and communications often aren't very consumer facing, so it takes some digging to figure out that you even can file a complaint. And when you're hitting a ghost network, you're typically doing so because you or a loved one is ill. So you're really at a time in your life where you are least equipped to read regulatory text and go digging through Google results. So there just aren't complaints coming in, and that camouflages the problem to regulators. And they're not making up for that gap by going out and affirmatively seeking information about this issue. And then when they do get information about the issue, they tend to settle either without any penalties at all, just making agreements with plans that the plans promise to fix errors in the future. In some cases, these agreements might not even apply to the entirety of the directory. They might just be limited to the specific errors that were uncovered in the complaint. Or when there are monetary penalties, they tend to be very, very low. So one California regulator was assessing penalties for directory errors that were under $10,000. And when you think about an insurance plan with billions of dollars in revenue that's routinely paying for surgeries that cost over $1 million per surgery, that's just not going to make a dent. So the regulators both aren't hearing about the complaints and then don't have the tools to proactively address them. And part of this is also driven by the way that these laws are structured. And I'm going to say this as someone who worked on the Hill, lives in DC, and has a lot of love for the people who write laws. Laws are written by giant nerds who assume that any rule that exists will just be followed. They often aren't written with an eye towards enforcement. And so you end up with laws that don't actually set out what accuracy means, or don't make it clear who is permitted to enforce the law and what remedies they can seek. And so there's just not a clear roadmap either for the enforcers, even if they wanted to be doing it and did want to take a larger role in this process. From the consumer perspective, the other issue is not just that the regulators aren't stepping up, but that consumer law, which would typically be the relief that people can seek when regulators aren't doing their work, is also closed off to consumers in most cases when health insurance is at issue. So most state consumer protection laws, either explicitly or in practice, carve insurance out of them. Health insurance is considered to be a highly regulated industry because there's a separate state regulator. And so even if that regulator isn't actually doing any regulating, it's considered to be an issue that the court shouldn't intervene in. And I think this is particularly problematic because when you think about, when we look at the penalties that regulators are doing and the work that they're doing, they're typically doing very one-off compliance work. And when they think about the harm that consumers are suffering, they're thinking about what the insurance covers. So the typical remedy to a consumer under a directory accuracy law is that they will refund any costs that were assessed because the provider was listed as in-network but was actually out-of-network. But these ghost networks are also just a classic false advertising violation. The directories function as advertising both for the doctors that you have access to and also the promise that you will have an accurate directory, which is itself a valuable part of what you're paying for, that you won't have to go around and call every single doctor in your town or knock on their door. And so when consumers sign up to a network and pay a certain premium and then don't actually have any access to those doctors or have to sink hours of their time into finding a doctor, they're getting less than what they paid for. And that's a classic consumer protection violation, but we haven't structured our laws to think about it that way, even though for a lot of people, health insurance is going to be one of their largest annual expenses. And so that's kind of this stuff that I've been talking about. This is mainly at the state level. And that's because most of the action on directory accuracy and healthcare regulation is at the state level. There are federal regulations, particularly in the Affordable Care Act and Medicaid market, but those also are not a lot of practical help to consumers. So on the Medicaid side, states are supposed to be enforcing the federal Medicaid regulations, and the federal government's only remedy if it finds that a state is not adequately enforcing those, including the directory accuracy regulations, is to entirely cut off all federal Medicaid funding for the state. And that is a very drastic remedy. It has never been done because it is so drastic. Similarly, for the Affordable Care Act, for the federal government to enforce the federal regulations at the state level, there has to be a finding that states have essentially completely failed to do any regulation whatsoever to protect consumers. And that's also a really, really high bar that has never been invoked. And so when you put all of this together, this doesn't mean that no regulation is happening, but it does mean that all of that regulation is getting outsourced to individuals like Ravi and his mother. There are directory accuracy surveys happening, but they're not being done by the plans. They're not being done by the state. They're being done by individual people who really don't have the time to be doing it and should be looking after themselves or need to get to work, or care for family members. And so the effect is, it's really just taking the pain of this problem and putting it on the people who can least afford to bear it. So that's the big picture of how we got here, and a lot of the reasons we're not seeing movement on this issue. In terms of how reporters can assess it, I would say that directory accuracy surveys are actually pretty easy to run because directories are almost all publicly available. So then it's just a matter of making phone calls. But I would also say that when we get that top line directory accuracy number, that's never the full picture. A very good top line number can conceal real shortcomings with regard to mental health or pediatric care or maternal health care. And so it's also important to break it down into those subcategories. And I think even kind of a very targeted survey is not going to fully capture the fact that ghost networks exist at a broad level, but also at an individual level. So even if a plan has a really great accuracy rate, if you signed up for a plan because you thought your specific specialist that you needed to see was in that plan, and they're in the 1% of people who are listed incorrectly, then you are still in a ghost network. And the same is true, if there are very few inaccuracies, but they're all clustered in the town where you live, for you, that's a ghost network. So these exist both broadly in terms of what's being sold to consumers and in the aggregate when we think about broad public health issues, but also very much as a story that can be told through individual people's inability to access care, as ProPublica's done such a great job of doing.
Thank you so much, Abigail. Dr. Trussman, let's turn to you to borrow a phrase from the software industry. Are ghost networks a feature or a bug? In other words, are these issues an accident or part of a plan of deliberate neglect? And why do you think they persist?
Well, if I may, let me take a step back and give somewhat broader context to why we are in this mess. So there, in immediate response to your question, it's a feature. It's by design. And let me describe part of that. Keep in mind that we live in a nation where healthcare is a consumer product. Healthcare is not a human right, number one. Number two, the issue of supply and demand in consumer environments generally drives an appropriate balance, resets the theory. That does not happen in healthcare in general, nor does it happen in psychiatry, psychology, mental health, and addiction broadly. There is a profound disconnect. And in part, that is in turn driven by the historic stigma associated with mental illness and addiction. As so many people will have experienced, they are embarrassed if they call and can't get an appointment, which would lead to a historically difficulty with them reporting and complaining because of the intrinsic stigma, still, I argue, associated with living with mental illness and addiction. So we are living in a real shortage, and whether it is the Surgeon General or others who have reported that we are in a crisis of mental illness, a crisis of addiction, a crisis of shortage of clinicians that is only projected to get worse. There is a disconnect in the reimbursement or the pipeline to growing access to care. So it's important to keep all of those factors in mind as you're thinking about this element of provider directories. So as Abigail mentioned very appropriately, you're, as a consumer, typically in commercial plans, choosing one over the other. If you are young, healthy, you'll just take whatever is the least expensive plan, very typical. But as we age, as we have family to care for, as we have more complex illnesses to deal with, we start being more selective. So we're making these choices on the basis of not just the copay and the deductible, but also who is in the plan for us to see. And so if this applied to any other area of consumer purchasing, and there was such a disconnect between what's on paper and the reality, we would simply call it fraud. It is fraudulent advertising. But those laws, as Abigail mentioned, are, because they are different state regulated, health related issues, all too often fraud is not brought to bear as a legal construct in these cases. So when we're talking about this now, let's keep in mind that care delayed is money made by the insurance companies. So the longer it takes people to get into care, that's care that the insurance company is not paying for. There are lots of misconceptions that, the 17+% of our gross domestic product that we, provide to healthcare goes to all of the hospitals and the doctors. And that's just not accurate. So much is siphoned off by those who are administering pharmacy benefit management and the insurance plans. And they will typically remove 30% off the top of the money. So a lot of these issues are following the Willie Sutton principle. It's about the money. And so the insurers are focusing on money. The delay in care has direct impact on how much money they save. It also has direct impact on the pain, suffering, and exposure to greater morbidity or mortality for the consumer of care who's being denied access. So these are some of the real issues. So just like all of the issues of what's called prior authorization, pharmacy benefit management, all of these are features that are baked into the fabric of healthcare as a way of saving money for the insurers at the cost of the consumers of healthcare when we are most vulnerable. So these are real challenges that we grapple with. And I love that Abigail used the word wonky and nerd. But the reality is this is anything but. This is bread and butter. And as healthcare reporters, the more y'all understand the value of conveying these challenges to your audiences, the more people talk about it, the more we all understand it, the more we will be in a position to shift this dynamic. Look, insurance companies, like other finance entities, have access to minute, if not millisecond to millisecond data. They know where their money's going at any given moment. It's a bit specious to say they can't keep track of the providers and put the burden on the clinicians to update and report, keeping in mind that clinicians got into the business of healthcare generally because they love taking care of other people, not because they love filling out forms and arguing with blank faces and anonymous people at the other end of a phone line. So let me stop there to open up opportunities for us to have a further conversation.
I think you're still on mute.
Sorry about that. Thank you so much, Dr. Trustman. I'm going to turn back to Max and ask him to maybe share a little bit of some of his tips for reporters either operating at a local level or state level who want to delve into these issues in their community.
Thanks, Michelle. I think one thing that's worth noting that is that as I mentioned, we started this project at the beginning of this year. While I have covered mental health and addiction care inside hospitals, and written about the opioid crisis, or written about the barriers to care in general. Like, I had never written about insurance aside from like Medicaid expansion and more from a broader policy perspective, but never had spent much of any time focused on insurance in the way that I have this year. And so I think just in the same way, when I first reported on Medicaid or Medicare or any other complex portion of how healthcare is delivered in where I live in Georgia or elsewhere around the country, it's an intimidating thing to get into, and so I think a few places, if I was to start over and have some sort of advice, I'm going to share my screen now, but I think these are a few of the places that I would encourage y'all to start. And I think first and foremost is to talk to experts, from that are in your own city or are are the ones testifying at your state house, and getting just wrapping your arms around like what are the specific state regulations, or, in this case around network accuracy, and how do they compare to others? Are they like where does it fit into the broader landscape of what is expected? Like what can one person reasonably expect in terms of a protection from the insurance regulation in their state? I think when we're talking about experts or advocates, some of these folks will be at the university level, professors of healthcare or health policy. I think also sometimes the experts locally are consumer advocates who maybe either have started a nonprofit because they had experienced a problem with insurance getting in the way mental health care for a loved one, or they're at like a consumer watchdog group that really focuses on like the agencies that are the apparatus of how insurance is regulated in your state. So start there, and I think also talking to people in other states as well, or nationally, that can give you a 30,000 foot perspective is really important, just to understand the landscape. State agencies, as Abigail mentioned, are vital to understanding how enforcement of insurance companies happens. And you may already know this, but just in every state, there's generally two main agencies. There is for some private insurance, and specifically plans that are purchased for individuals through health, like through an exchange, or fully funded, what are known as fully funded plans, fall under the purview of the state insurance agency or commission. Medicaid, while CMS does have some responsibility, is also administered at the state level, and the state Medicaid agency typically has oversight of the Medicaid managed care contractor as well. So kind of understanding what agencies look at are important, and then what records you can get. I think you can send in records requests for provider directory or listing complaints. You can see if there are any enforcement actions, and then there are these documents called market conduct exams, which typically happen every few years, but the insurance agency regulators conduct a review of like whether or not how the insurance company is performing, and then sometimes they list out violations or penalties in those documents as well. I think from there, finding, sometimes you can do this through complaints or through hearing people testify or through being connected by an advocacy group, but finding people who have been harmed or have had a problem with getting, not being able to access their mental health care benefits. Finding those people are important, not just to like hear their story and understand it firsthand, but also because they're going to be able to get you potentially access to insurance records and as well as medical records. If they were able to get that far. In particular, there's a provision of HIPAA that allows individuals or anyone authorized on their behalf to do this to put in a formal request for what's known as a designated record set that allows one or to get access to the records on hand from the insurer, including case notes from people that were handling a particular issue they called customer service about, or a case manager, to recordings of some of those conversations, and so on. And these records, I think, will really get you beyond just like the a top line response from a company. You can actually show like specific things happening in motion. If you had a chance to read the story about Ravi, the whole top of the story is built around one call recording in which Ravi is trying to get closer to the care he needs, but is running into the ghost network problems. And it's very clear that for various reasons, you'll see that the customer service rep is just unable to help him in the way that he needs at that particular moment. I think having those records in hand is important because it gets you past the bureaucracy and close to like the actual experience of people who are insurance customers. And I think if you can get that close, your readers or viewers or listeners will care in a way that they may not have been able to connect with in a more abstract sort of policy conversation. And then finally, and we've done this as you can see on the screenshot on the right. I don't like to lead, even though ProPublica focuses on accountability failures and problems in our reporting. I didn't want our readers to be left without any pathway forward in terms of getting around ghost networks. It is not easy for anyone to do that, but in this additional piece that accompanied Ravi's story, experts shared their thoughts on like what are the specific ways you can protect yourself against ghost networks, or if you run into those problems, what are your rights and what are you able to do to get past an insurance company that is not helping you get the care that you paid for and are entitled to through the contract you have with that company. So those are the main buckets of things that I would suggest anyone to cover to go after first as you're embarking on reporting on ghost networks.
Thank you so much, Max. We're going to turn now to the questions from our audience. And just as a reminder, if you have a question for our panelists, please pop it into the Q&A. I'm going to start out with a question from Johanna Ryan, who says, a recent paper showed prescribing of antidepressants to youth was up 66% between 2016 and 2022, but most were not seeing a mental health provider. 40% of scripts were issued by nurse practitioners or physician's assistants, 25% by family doctors or pediatricians, and only 26% by a psychiatrist. Does this match your findings, and is it a good thing or a bad thing?
Well, I can speak to the numbers because those reflect the reality of the workforce. Most people who seek care for psychiatry are actually treated by their primary care clinics, and only then potentially refer to psychiatry. And because of the limited number of psychiatrists, there are about 50,000 of us in practice around the nation. And the challenge, certainly with kids and teens, is the special needs for the children, the families. More and more, we are working with nurse practitioners, PAs, others to be able to deliver the care. And there are real issues and challenges with that. So is it ideal? No, not necessarily, but it is the reality. And we're struggling now to come up with appropriate strategies to stratify who should see whom for what level of complexity of care.
We have a question from Rushir Karmali, who says, how do these ghost networks affect, I think Rushir means Medicaid beneficiaries specifically? Do states have ways to keep track of this information in the same way that private insurance companies do?
Happy to jump on this one. So Medicaid beneficiaries are in many ways some of the people who are most vulnerable to ghost networks, because when you think about like insurance, employer insurance, you really have your employer acting as an intermediary with you. Medicaid has now been so dominated by managed care that it's the same large companies providing the care, but without that person who can reliably at least try to negotiate with you or for you. And I think there's also the issue, which I mentioned, that there's not really right now a good lever to ensure that states are actually enforcing the regulations that exist. The ones that do exist are good. We're just not seeing them turned into action. I think one avenue that I have been pushing for years, I think would be really interesting, is most states actually write the network, the provider directory accuracy regulations and the broader network adequacy regulations that they're a part of into their contracts with Medicaid managed care organizations. They're a contractual requirement. And so the failure to comply with the contract, but nonetheless get paid with the contract, presents what's called a false claims issue. Basically, you're billing the government for services that you didn't provide. And so I think that is something I would love to see more states exploring, but I think it is a really under-discussed issue. And it's also problematic for Medicaid enrollees, because in a lot of states, Medicaid, depending on how states administer Medicaid, enrollees in Medicaid may not necessarily have a choice of plans, or may have just one other choice that's offered in their county. So they also don't have the ability that you see in other markets, particularly the ACA, to vote with their feet. They're kind of stuck. And Medicaid enrollees, they're more likely to have lower incomes, to be communities of color, to be facing disabilities. So it's also this population that is in many ways the least equipped to be taking 5 hours during a workday to call every doctor's office in their town. So I think that's a really, really ripe area for focus, because the state does have such direct responsibility for what's happening there, but isn't pulling the levers that they have in most cases.
And just to follow up on that, Abigail, and others, please weigh in too, but just more broadly, how are less advantaged patients, maybe being even less likely to obtain care in these systems given the barriers, and how does this issue grow worse in rural areas? And if I can tag on a Medicaid reference to follow up on what you're saying, I'm assuming that for Medicaid, we're talking about even exponentially fewer specialists on those lists. But let's just right now talk about the commercial aspect, and just being somebody who is not who's living in a remote area, or just doesn't have the resources to make 45 calls or something to find somebody.
Yeah, I think it is a very pronounced issue for rural areas, because there may be rural areas where there is only one doctor who practices that specialty, or we've seen, especially now after Dobbs, areas where there are very few OBGYNs or a lot of counties in America don't have a mental health care provider. So if your plan mistakenly lists that one person as in network and they're not, that is a much larger problem for you than if you were in a city and there are other options that are relatively geographically accessible to you. You still have to find them by making your way through the phone trees, but there is at least someone you can physically reach. So there is a real concern for people in rural areas. And yeah, in general, I think this is an issue that hits hardest for people who are from disadvantaged communities, both in terms of having the skills, the time, just the energy to go through and make these phone calls and to navigate the processes. And then if it doesn't go well, it's that effort and need to navigate complex systems times 10 if you want to file a complaint, if you want to push an appeal. Something I think is under discussed, but also really relevant here is language access. So a lot of state insurance websites, they're only offered in English. They may also be offered in Spanish, but that is only scratching the surface of the languages that people speak. Or also, if you have to make a phone call to make a complaint, to require either a phone call or an email rather than accepting a variety of means of contact is very difficult. Phone calls are hard to do during work hours. Emails require an internet connection. And so just that there hasn't been the work done to really broaden the ways that people get in touch, and even moving beyond the paradigm that people have to get in touch with you and actively going into communities and reaching out to them and proactively offering them resources and contacts. But I think the other dimension to this that I think is under discussed is the way that it adds to the caregiving burden. When I was writing my paper, I talked with a lot of people who were doing this on behalf of relatives, and they were almost all women. So there's also a huge gender dynamic with this, as there is in a lot of caregiving. I talked with one woman who had spent hours trying to find an in-network psychiatrist for her brother who had severe mental health crisis, and finally worked out that because she was self-employed, it was financially the better option to just go out of network because she was losing so many hours of client work just trying to make the phone calls. And so I think this is also one of those things that just takes the already kind of difficult and wonderful, but often emotionally and time-consuming work of caregiving and makes it so much harder than it has to be, and takes people away from their loved ones at a time when they really need to be as present as possible.
And just to tag on to that, keep in mind, those who are being paid via a Medicaid option, generally, they're not seeing private practitioners. Private practitioners of any kind almost never take Medicaid. It's only federally qualified health centers, certified community behavioral health centers, community mental health centers, or academic institutions, treaters of last resort, public hospitals are going to be where people with Medicaid are being treated. Given that, and the access and capacity challenges mean that they may be waiting a very long time just to be able to get in the door. Even if the mandate is for these providers to see them, there simply aren't enough hours in the day to be able to do it.
And so what Dr. Trestman is talking about there ties in this broader issue of network adequacy that I had mentioned, which is kind of a bundle of regulations that we started to see after the ACA, of which ghost networks are a part, that deal with consumers' ability to actually see a doctor. So not what happens after the claim has occurred and it's being processed, but like, can you get in the door? And those are regulations like how far from a doctor, time to an appointment, the ratio of providers to doctors. And I think ghost networks is really foundational for all of these, because the way that most states enforce the rest of their network adequacy regulations relies on provider directories. So if you can't get the provider directory right, you're failing. It's like pulling out the bottom Jenga block. The entire thing is going to collapse because the foundational information you're using to assess compliance with everything else just isn't correct. I think that's another reason this issue is so important. It is just the regulatory building block for all the other changes that we need to see in the healthcare system.
We have a question from Stephanie Innes from the Arizona Republic. She says, a question for Max. What was the process like when you helped Barbara, and I'm assuming here we're talking about the mother of Ravi, obtain audio recordings of their calls with Ambetter, the insurer, and how long did it take to get them? Did you have to get lawyers involved?
We did not have to get lawyers, like ProPublica's lawyers, involved. I did not realize, ProPublica's team of reporters here last year had worked on a insurance series, related to medical and surgical care, but not mental health. And there was one of our engagement reporters, Maya Miller, and had put together a story that gave people a template to go get their claim files. For a long time, I thought we could not get those kinds of insurance records when I was reporting and talking to Barbara early on, because again, as I mentioned earlier, Ravi did not get care. So there was no claim in like from a therapist to request. Later on in the process, as I was starting to talk with those experts who were reviewing what happened to Ravi and weighing in on that, one of them had mentioned to me that there's actually there was a way to get other kinds of records and beyond just a claim being denied and so on. And so this was maybe the story came out in early September. That conversation happened in mid-June, and immediately, like I talked to Barbara and with the language that this one lawyer helped me, find within HIPAA, crafted a letter for Barbara to send to Ravi's and to Ambetter, and that portion of HIPAA requires the insurance company to send anything back within 30 calendar days. So as soon as we sent that, they were on the clock, and I had to get her to send some follow-up emails and to kind of get a little aggressive so that we can get the records back. And it wasn't until like early August when we had the tapes in hand, and it came in close enough to my deadlines where I had to do some like pretty dramatic restructuring of the top to really focus on that call, but no lawyers involved. It took 30 calendar days, from the point of having the letter sent. The final thing I'll say is that the only reason Barbara was able to get Ravi's records was because he had given her authorization to do so before he passed. Had he not done that, there would have been no way to have gotten those records.
Thank you, Max. And there's been some questions in the Q&A, and I'll try to channel all of them with a kind of uber question here, which is about this idea of who is at fault, and do the providers bear some responsibility for updating the networks and so on. And maybe Max, will start with you, and then I'm hoping Dr. Trustin and Abigail can weigh in too. But in your deeply reported story, Why I Left the Network, you and your ProPublica colleagues describe why half of all patients seeking mental health care are unable to access it, even though most of them have insurance. And as you reported, this is devastating. And part of this problem is the list, and part of it is that many mental health providers don't accept insurance. So are they just too lazy to change their provider listing? And are they just looking to make more money, and so they don't want to accept insurance? What did you find?
When we were speaking with hundreds of providers about why they had left networks, I think by and large the ones that the story we heard back from them was that they got into the business wanting to accept insurance and to see patients with Medicaid, patients with on the marketplace, and a full swath of patients. But over time, the combination of rates not going up, plus insurers interfering with the way that they could provide medical care, ultimately made it untenable in many cases for them to keep going with it and to continue to run a business of their own. Many mental health providers are solo practitioners or work for small group practices. I think even if when you do talk to insurers, they do their response is that they share responsibility with providers, and providers need to be updating directory information if they move, if they retire. Providers we spoke with said even when they did that, it was common for them to remain in the directory and still be getting calls months or even a year after the fact. And I think that like kind of goes over to this broader idea of like, at the end of the day, any of us with insurance have a contract that we enter with the insurance company and, over their health plan. And we are paying a premium in exchange for access to this directory and to the care that we may someday need. I, as an individual consumer, am not in a contract with a provider. It is ultimately the plan that is the one giving me this directory, and therefore, it is their responsibility to be updating this directory at the end of the day. And while I think, I do hear what they are saying in terms of like providers need to be doing a better job in terms of correcting, in some cases, correcting their the inaccuracies sooner. It is the plan that is the one that's entered the contract with you, not those providers, and therefore they need to be responsible for fixing the problem.
Dr. Trustman or Abigail, did you want to weigh in on this?
Well, it is so easy to pass the proverbial buck to the clinician, but think it, as you think it through, if the insurers even did something as trivial as sent an email once a week to their directory and to all of the clinicians saying, are you still accepting new patients? Are you still able to provide more care and so forth? And simply set up a response, yes, no. In theory, this would take care of that issue. But they're really smart people. They're choosing not to do this, and they're choosing to put the burden on clinicians to find the time to go to a website, to drill down, to find out and put the information in. And then, as Max says, it's not like they update it in real time. They may not update it until annually, because again, it's not convenient for them, and there are trivial or no financial penalties for them to not comply with the regulations.
If I can also add there, I think, as I'm watching some of the questions come in, even if we were to presume that providers did not respond to directory inquiries, I wanted to go back to a point that Dr. Trestman made earlier in terms of the sophisticated data, systems that insurance companies have. They have the ability to see the money going out the door in terms of claims processing and all of that. There is a way for them theoretically to look at, like, if a provider has not accepted, has not processed claims within that insurance for people in that insurance network over a certain period of time, over 3 months or 6 months, that could rule someone out or kind of raise a flag about there being a potential provider in network, listed in network, who is not really accepting new patients and could further address the issue.
Yeah, and I think that there's also examples from a lot of other industry, like airlines. There are ways to build these systems, and there are not enough of them, but there are some insurers that do this well. They tend to be smaller, they tend to be locally run Medicaid plans that aren't attached to these like conglomerates, but I think they prove that it is possible. And there's been a study showing that the directories are less accurate than Google. So we're not talking about a very high bar here to get better. On the out-of-network issue, that there just aren't enough providers in the network, that's its own very thorny issue, but I did want to mention that there is actually a requirement for all Medicaid programs and in most states separate from Medicaid, that if a enrollee cannot access the type of care that they need within a reasonable amount of time in network, the plan is obligated to provide that care from an out-of-network provider and cover it as though it was a network. The issue is that there's just no way for enrollees to enforce this requirement. And so this is another way that it's just really hard for people to actually enforce these directory accuracy rules. And so they end up being forced to go out of network and cover the costs themselves or forgo care entirely.
So we're officially past our time, but I did want to see if we could squeeze in, if you all are amenable, maybe just one or two questions. And I did also want to just mention in passing that one of our attendees named Susan Frager mentioned that she's working with a therapist who's being told by an insurer that she will be financially responsible for directory errors, which is interesting in the light of what we're all talking about. But I'm going to try and channel a question here and also just ask a broader question out of that. Jeffrey Gordon, MD, asks about California's Affordable Care Act agency and suggests that they're doing a better job with all this by incentivizing insurance companies to be more appropriate in consumer services and quality, and asks, is this model, why is it being used in other states? So I guess I wanted to ask both Abigail and Dr. Trustman, because you've both done a lot of thinking and writing and congressional testimony about where we can go from here. First of all, do you even agree with Jeffrey Gordon's assessment that California is ahead of the game? And just what do you see as paths to improve what seems to be a pretty abysmal situation?
I think I actually looked at California in quite some detail for the paper that I wrote and have continued to keep an eye on the state. And unfortunately, what we've seen there is the numbers on directory accuracy are still really bad. California was one of the first states to pass a law when it became apparent that this was an issue. Their law is on paper, probably one of the stronger ones. And there is also an effort currently ongoing to amend it to make it stronger. But no one had really checked to see that it was working. There was this assumption that because it was on the books, it was being carried out, it was all taken care of. I, through a FOIA request, found this data set that functioned essentially as a de facto directory accuracy survey. And that data showed that the accuracy numbers were still very, very bad. And this is data that the state had, just no one had put the pieces together. And I think this again comes back to the issue of laws not being written for enforcement. There's a lot of laws in California directing companies and how they should act, but there is very little to actually hold them to that. Again, the fines tend to be very low, although there are signs that is hopefully changing. We're still relying on affirmative consumer complaints, which is not great. And we're still talking about relief in response to specific instances rather than this broader problem of falsely advertising a product to consumers. I think the California effort I'm most encouraged by is actually a lawsuit that's being brought by the city of San Diego right now against Molina, Kaiser, and the Centene affiliate in the state called HealthNet, which is alleging that these directory errors constitute false advertising. And in the course of this case, they actually got testimony and a court filing from the designated regulator for the plans in California, where the regulator essentially said, this is not enforcement work that we are doing. Like the effort of the state is not stepping on our toes because we just don't actively enforce this issue. We only respond to complaints. We are only able to really offer limited relief to specific consumers. And that is not the type of broad-based affirmative enforcement that we need to really move the needle. So I'm very hopeful. The California case, there was recently a good decision from the city from the Court of Appeals, and we'll see where it goes from there. But I think it just really highlights this issue that even the best laws that are passed, they don't actually improve people's lives unless there's someone making sure that they're followed.
Yeah, thank you, Abigail. And Dr. Trustman, I know that you've testified on just ways to go forward. What would you maybe want to add to some of these really great insights from Abigail?
Well, first, I think there needs to be a national standard. Even if the federal government outside of Medicare Advantage does not have regulatory control. It can certainly develop appropriate standards to encourage the states to follow them. Number one. Number two, they should appropriately determine the auditing protocols and the financial penalties associated with them to set a national standard. Because there are two downstream consequences of not doing so. When one state increases the enforcement, insurance companies may shut down that plan in that state and move to another state where they are not financially exposed. So it's really important to think through the consequences of one state really doing an effective job, because it will have downstream consequences. The other is who pays for it, and to make sure that it isn't ultimately the consumer that just ends up paying more for what they were supposed to be getting, and that rather an appropriate amount of financial compensation occurs to the public stakeholders, or shareholders rather, of these, generally speaking, publicly held mega companies.
Thank you. And I want to just say that our webinar has concluded. I want to thank Max, Abigail, and Dr. Tressman for their insights, and to the audience for all their great questions. We'll be emailing you a survey asking for your feedback on today's program and for your ideas on other topics of interest. And we're also just sharing with you some ways to learn more about our programs and opportunities with the Center for Health Journalism, or to share your feedback. You can find more information on how to do that here. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. Thanks so much for joining us, and have a wonderful day.
Thanks for hosting us.